Hello, this is Dr. Brian McDonough, and welcome to the Dr. Brian McDonough Show. Today we have a very special guest. We're going to be talking with Dr. Gerard Kreiner about some of the major developments in the treatment of pulmonary disease. He works at Temple University School of Medicine, the Lewis Katz School of Medicine, and he has been a physician there for many years. Some of the developments are incredible. That's all coming up next on the Dr. Brian McDonough Show.
So the symptoms of it are really cough, really a non-productive cough. You don't bring up mucus with it. And it starts with shortness of breath with exertion, usually going up stairs or going up a grade. Patients start to notice it first. Here, they notice it when they try to go to shore and walk on the beach. And then over time, it becomes more progressive that they can do less and less without getting short of breath, and even occurs when they are at rest. So it can be progressive in some patients. The rate of progression varies from one patient to the next, but in some cases, it can be a very difficult problem that may be one of the most common reasons that in patients that are refractory to treatment may end up requiring a lung transplantation. So there's a range of different therapies that patients should be aware of. If they have symptoms of cough and they have symptoms of shortness of breath and it's chronic, they should see a physician because there's simple tests that can be done, like a CAT scan of the chest, that can help, coupled with breathing studies and some blood tests that can help come to the right diagnosis and get the right treatment.
Anything put people at risk for this, for instance, cigarette smoking?
Cigarette smoking is a big risk factor. Some patients with connective tissue diseases, like I said, rheumatoid arthritis or scleroderma, and then some patients that work in certain occupations around sandblasting or asbestos or really in some parts of actually Pennsylvania, mid-central part of the state, borreliosis when they work with fluorescent light bulbs, and even with aluminum workers in the western part of the state.
What are you doing at Temple and work that you're done as far as research and things that have improved treatment of this? I know you're doing a lot of breakthroughs, investigative treatments, and things that are making a difference.
Yeah, there's two things. One is that we have a very robust, energized screening program for lung cancer that's system-wide. And with screening for lung cancer, you might find 5 to 8% of patients, because of the prior smoking, that may have early onset of interstitial lung disease. So finding that patient group at an earlier stage of the disease to encourage those who are still smoking to stop smoking, or those who are former smokers to see if they're a candidate for other forms of therapy. We have a large clinical research program working with industry and NIH with different really agents that will work at different pathways of the lung, trying to abrogate the progression of it at an earlier stage of the disease. So clinical trials, clinical programs, and using really state-of-the-art detection and physiologic testing to determine how impaired patients may be with it.
So somebody who would come to you as a patient, would they be someone who's already seen their family doctor or even seen their pulmonologist? Who would be someone who would come to Temple for this type of treatment?
I mean, for me or the rest of my group that deal with patients with interstitial lung disease, if patients have cough and shortness of breath, they can go to their primary care doctor or their primary pulmonologist. We get patients that are either self-referred or go to their primary or pulmonary doctor who want to take advantage of some of the clinical trials that we have, or if they're in the later stages of the disease, then there might be other therapies, both medical and even lung transplantation, that might be a consideration. The world of transplantation has changed extensively over my 30-year career. That transplants now are much more tolerable than they were in the past because of the range of anti-suppressant medication, immune addressing medication that are less toxic in combination, coupled with prophylactic medications for infections. Those have allowed us to advance the care of patients and increase long and durable survivals with long-term improvement in lung function in patients. Plus, with the new tools that allow us to extend the life of a graft outside of a donor, allows us to have the ability to transplant more patients by showing the viability of an organ, and also go further to get a transplant organ if needed to be for the appropriate recipient. So I think for patients that there's always hope. And if you have symptoms and you basically shouldn't sit there, you should be seen by a doctor. And if you don't get relief from your first go round that you should ask further questions and see what other options that you have. There also are good, for interstitial lung disease, good associations to think about where you can get reliable information. One is the Pulmonary Fibrosis Foundation. The other is youandyourlungs.com as a nonprofit that's looking at to give information for patients with lung disease. And the NHLBI, National Heart Lung Blood Institute, has a very good website for information for patients regarding lung disease and specifically interstitial lung disease.
Dr. Kreiner, I know how busy you are. I want to thank you for taking time, especially late on a Friday when you probably
Happy to do it.
want to get home. I appreciate it, and thank you for taking the time.
Okay, Brian, have a good one. Nice talking to you.